Bosali. Our next presenter is Dr. RAMYA APPANRAJ, and her presentations on macular hole management as well, tips and tricks.
Macular hole surgery is one of the frequently performed surgery in the vitreoretinal subspecialty. Though the surgical success rate is quite high, we do encounter occasions where we face the failed persistent macular hole. We describe a few techniques that are available for the vitreoretinal surgeon when faced with such an event. Higher percentage of gas. After performing fluid air exchange, wait for 10 minutes for the BSS from peripheral retina to trickle down to the posterior cone so that we can do more complete fluid air exchange. Then inject higher percentage of gas to maintain the dryness of macula in the post-op period. Any increase in IOP should be managed. Drainage of macular hole. After fluid air exchange, using 41 gauge needle, the macular hole should be drained, taking care not to touch the edges of macular hole or underlying RPE. Soft tip cannula can also be used for this purpose, but it carries the risk of injuring the edge of macular hole or underlying RPE. Autologous blood or serum or thrombin. After performing fluid air exchange, a drop of blood or prepared serum or thrombin can be instilled on the macular hole. Hinge flap. A large ILM flap is peeled from its temporal edge of previous ILM peeled area, taking care not to detach it, and this flap is then mobilized further to cover the macular hole. Free flap technique. The hinge flap cannot perform if the previous area of ILM peeling is large. In those cases, free flap technique will be preferred. An ILM flap is created from the edge of previous peel. PFCR is injected to prevent the loss of free floating ILM. The free flap is then detached from the hinged edge and advanced to cover the macular hole. The fluid air exchange is performed, followed by gas injection. Relaxing episiotomy. In cases of very large macular hole, a 25 gauge curved scissors is used to make the arcuate retinotomy 500 to 700 microns away from the temporal edge of macular hole. After fluid air exchange, using 25 gauge soft tip cannula, mobilization of temporal retinal bridge is performed, thereby narrowing down and closing of macular hole. Anterior and posterior lens capsule. In eyes where mobilization of free or hinged ILM flap is not possible, the use of anterior or posterior lens capsule has also been described. After performing capsular excess, the capsule is preserved in balanced salt solution. Then a piece of capsule is trimmed to accommodate for the size of macular hole. And this flap is placed over the macular hole after fluid air exchange. A piece of posterior capsule can also be utilized for the same purpose. Use of heavy silicone oil and supine portion has also been described for rectal macular hole.